Hey everybody, this is Erica Mello, and welcome to another episode of the podcast. And for those of you who have been listening to us for a while, you'll know that in the end of last year of 2024, Susan and I decided to take some months off of the podcast just because we've been doing this for so long. I think we're at well over 200 episodes at this point. And for those of you who are new listeners, feel free to listen to our old episodes. Gosh, our some of our top rated episodes, ironically, are some of the earlier ones that we did. There's a list of them on our website at toughtotreat.com, as well as just on wherever you listen to podcasts. And so I wanted to jump in here uh, just to do a real shorty. I always say it's short. It never turns out to be short, but I'm really going to try and keep this concise and condensed. I listen to a lot of podcasts myself, and we recently received an email from somebody who had been listening to a lot of our episodes all at once, and so I'm trying to keep this a bit shorter. So in case people do that, it will allow you to watch or listen to actually several episodes at once. So for those of you who have read our emails, we thank you. And those of you will know that I am in the process of doing my doctoral dissertation for my doctorate of science degree, and it has to be in women's health. And the topic is menopause. So I'm actually looking at physical performance between pre and postmenopausal or menopausal women. I'm at the final stage of the research proposal at this point. So I wanted just to briefly talk about that, but I also wanted to present a clinical case scenario because I know that we've gotten a lot of questions over the years from listeners on our clinical cases. And, it's what we do best. And, our nuanced approach really allows for some really interesting presentations. And, we've gotten a lot of really nice and sweet testimonials over the years on our episodes. So I will definitely talk about this patient of mine who actually she is in menopause. So I'll give you a little bit of a teaser. She is a woman here in New York, where I am. For those of you who are new, I'm a practicing clinician here in New York City. And she lives in a borough here called Brooklyn, and avid, runner. She's about 48 years old and very active on hormone replacement, on estradiol patch and progesterone. Okay. And it runs, works out with a trainer, and, does a lot of mountain biking, very active. People often think of people in New York not being active, but that is the farthest from the truth, honestly. There's a lot of people here who do a lot of this mountain biking, and they do them generally outside the city. So she was one of those people who just really, really, active in the city, outside the city, work with a trainer, etc. So her chief complaints, and I put that as an S, um, left-sided neck pain, left-sided shoulder pain, left-sided low back, left-sided hip pain, left-sided foot pain, left, 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 left. And for those of you who've listened to for a long time, we all know that when someone's loading, one side over the other, that you need to see if that is a dominant strategy across multiple tasks, right? Does she squat to the left? Does she do a split squat? Is she, translating to the left? When she's walking, when she does a step forward, she's translating more over to that left side. Is it more, you're looking at non-optimal movement, okay? A lot of people are like this and they can adapt really well. And when they move, they're fine. But we're the detectives, right? We're looking for the movement pattern that is dominant across all tasks, right? So with her, it was left. Uh, Brief medical history. Will be brief because I'm going to go into her later. Fell off a bike, just literally flipped over. It's amazing she didn't break anything. And she had, left-sided, they landed right on her shoulder basically, and negative for fracture. Of note, she had a Jones fracture on her left foot about a year ago. That is important. And so I'll just say this one thing before I get into a little bit about menopause. When people offload an injury, what region of the body do they offload it? What I should say, take that back. What region of the body do they use to offload their symptomatic side? Right? Left foot pain, she's going to go to her right, right? But she didn't. but she didn't. Um, so what are we thinking? Can the pelvis easily move us off? Not really. It's usually the other foot that pushes us. So the left foot's going to push us off, right? But the region of the body is the thorax. It has a lot of people say that it's very stiff, but it really is not unless you've had severe trauma or a subluxation or trauma to the area. It's actually fairly mobile. What we see are a lot of common bracing patterns, a lot of neuromuscular patterning in the thorax that makes it appear stiff, but in reality, it's not. Um, so she just offloaded her sort of symptomatic sides with her thorax to the right, right? So just think about that going forward, and I'm going to get into a little bit of her case later, knowing she is in menopause. So it's gotten a lot of traction lately. Obviously, a lot of social media influencers are talking about menopause and what to do, and it's great. I'm just thinking there's so many women out there who have no idea they're in menopause, and if they're experiencing these symptoms, they're dismissed for the most part, or they have to go to multiple practitioners to get answers, and that's more common than you think. And a recent report from it's called the SWAN study, which is the study of women's health across the nation. It examined, I think, over 2,000 women aged 40 to 65 years of age. And 19% of women in the 40 to 55 years of age range reported mild to moderate physical functional limitations. That's a lot, 19%. And get this, it increased to 50% of participants who are over 55. I mean, that's a significant amount. And then almost 20% of women over 55 reported severe to extreme mobility and disability. Just think about that. Let that one sink in. Okay. This past summer, Dr. Vonda Wright, who I actually saw here speak in New York at a small event we had, she and several co-authors coined the term the musculoskeletal syndrome of menopause. And it was coined in a paper in 2024 in July, and you could get it easily online. It is open access. And she outlined a lot of these collective musculoskeletal symptoms associated with the loss of estrogen as women move into menopause. Similar to what I just mentioned, she estimated that well over 70% of women globally will experience, severe musculoskeletal symptoms, and 25% will actually be disabled by them. And I'm not just talking vasomotor symptoms. I'm talking physical limitations, chronic pain, very, very common. And in 2024, McKinsey, whoever is in women's health, they should be, or practicing in women's health, they should get on McKinsey's list. They have a lot on a lot of work and reports done on closing the women's health gap. And in a recent report, they noted that of all the women who go through the menopausal transition, only 25% will seek treatment. That is really low. Why is that? Why? And as I mentioned earlier, I attended an event in New York City, and I would say half the room was probably of menopausal age. I would say 10% of the women knew they were in menopause. And we're talking maybe highly educated women, right? So I was stunned. And then if they either didn't know what to do, or then you had the opposite end of the spectrum, where if they were doing everything they possibly can to get themselves through this, which is, I really think, where we need to go. So in this same McKinsey report in 2024, they talked a lot about, the percentage, the research gap, and just bear with me, this will take 30 seconds, but it's really important. Women's specific conditions, underfunded women's specific conditions, actually, so PMS, menopause, maternal hypertensive disorder, cervical cancer, endometriosis, they comprise 14% of the total women's health gap as of this particular study in 2024, but they get less than 1%, 1%, less than that of the cumulative research funding. As a comparison, diabetes makes up 2% of the women's health gap, but it receives 12.5% of the research funding. I'm all for research into diabetes. My mother was diabetic, insulin dependent. So I'm all for diabetes research, but that the comparison and the difference is stark. And it's no secret as we get older, we experience a loss of muscle strength and power. This particular patient I was talking about earlier, I mean, when I watched her squat, when I watched her split squat, you name any functional movement test you want, this woman had a severe loss of control. Okay. And in my dissertation, I am actually looking at the physical parameters I'm looking to get approved are hand grip strength. Hand grip strength is like the holy grail. It's almost like a control group for me at this point. It's common, it's measured in all the studies. There have only been 5 high quality studies looking at physical performance between pre and postmenopausal women, or premenopausal. A lot of them put premenopausal, peri, and post. Perimenopausal is tough because there's a lot going on. I have somebody I know down in Miami doing a large scale research study. He's having a hard time recruiting women in the perimenopausal group. It's really tough group to get. And so my study will be on premenopausal and then menopausal. So, and the parameters, as I said, hand grip strength, I'm looking to do single leg squat, just so we know as a common clinical test, not highly valid or reliable, unless you're using motion capture, which I will be doing. I have access. I'm lucky enough that I do have access to 3D motion capture here in New York. So, but just think twice about that particular study, because about that particular measure. What are you measuring when you're doing a single leg squat? It's not highly valid or reliable. You will find studies that show that it is valid and reliable, and I did, but wasn't convinced. I was not convinced. Allison Grimaldi did a master class on gluteal tendinopathy. I would highly recommend. It's online. It's a PDF. Anybody who's very common in women, and especially as you get older, women who are not in menopause have gluteal tendinopathies. But as I'll mention in a second, estrogen sits in tendons. So for the single leg squat, she noticed that the hip adduction angle was increased in women, and in many studies we've seen that, and so that's what I will be measuring. Okay, in women in women in menopause, you see a lot of that loss of control at the hip angle. I'm also looking to do vertical jump height. I'm going to talk about power in a second. That's one really lower extremity measurement of power. It's been done once before in another study. I'm looking to do these are pretty basic and definitely valid and reliable. The sort of 4-way multi-directional reach test, reactive balance, and also reactive postural sway I'm looking at, which is part of the Fullerton Advanced Balance Scale. And then finally, upper extremity power, a seated medicine ball push. You try pushing a 6-pound medicine ball against the wall 5 times, and you're going to see how hard that is. Okay. So, as we age, as I mentioned, we do experience a loss of strength and power, and it really starts probably in our 30s. If I only knew that back then, right? It depends on many things, right? And it occurs earlier in females. It just does, right? Than males. It's been shown in the research. So we know that strength is force, right? How much force can a muscle generate? Power is velocity, is that velocity times force. And so, it has to be really noted and mentioned that estrogen receptors are found in muscle tissue, which they are. They seem to be expressed more specifically on type 2 muscle fibers. Okay, type 2. We know that type 2 fibers are reduced in number and size in menopausal women, right? And since these types of fibers, type 2 versus type 1, the type 1 are more of your slow twitch, right? You're longer acting. The type 2 fibers are really important for producing fast and strong contractions like power, right? Producing more power. And this is definitely worth investigating, which is why I wanted to add those 2 measures of power in my study. And in one of the research studies that I did read, they definitely showed a preferential sense of type 2 muscle fibers versus type 1. And these fibers are definitely like probably 3.5 to 4 to 5 times faster than type 1 fibers, right? And so, which is why I chose, as I mentioned, the upper extremity seated medicine ball push and the vertical jump height power measures for my dissertation. And before I go in a little bit onto the case study, I think this is important. A study, I can send this to anybody who wants it. It was done by Anton et al., outlining the sex differences in weightlifting and powerlifting. okay, with increasing age in both men and women. And this is important. So listen up if you're not. He concluded that the overall magnitude of the decline in peak muscular power appears to be greater in tasks requiring very rapid, highly coordinated movements, okay, where exquisite balance must be maintained, okay? So furthermore, these declines in muscular power are greater in women than in men only in weightlifting events, which is the snatch, the clean and jerk, okay, suggesting that women may experience a greater age-related reduction in tasks that require more explosive and complex movement, okay? In weightlifting and powerlifting, it's a little counterintuitive. The weightlifting events are your clean, your snatch, and your snatch, your clean and jerk. The powerlifting is more your deadlift, your chest press, right? So in these high ballistic type movements at heavy weight, women experience a much greater decline only in that specific study. And also in another study, I found that, leg press power, like if you're going to test some power, if you have somebody on a seated leg press or supine and they push out at 40 and 70% of their 1 rep max, the power explained more of the variance in functional performance than strength did. So power, in many studies I've read, is more associated, more closely correlated to functional performance than strength. Think about that one and how you could possibly use that in the clinic, right? So clinical pearl, how do you test power in the clinic? Do we test power? I don't generally check it the first time I meet somebody, unless they're coming in and they have a problem jumping, right? It's not something we test often. It's a functional test, and for those of you who are testing that in the first session, that's great. It's amazing. My patient, she had neck, shoulder, hip pain, all left foot issues. Do you think a loss of power in her upper extremity? Think about this: neck pain, shoulder pain, foot pain, uh, low back pain, fell off a bike, had multiple falls, right, over the years, also tore her hamstring. And just as an aside, for those of you who have any patient who has a torn hamstring or in their history, I don't care if it's 25 years ago, you need to include that on your areas of priority to investigate, because I will guarantee that will be an issue. I've torn my hamstring twice, so I speak from personal experience, okay? So don't dismiss a hamstring injury, even if the person has shoulder pain, okay? It may not be your priority area to look at first, but look at it, okay? What's the connection of that hamstring to the shoulder, to the neck, right? So I would say, yeah, a loss of power in her upper extremity would be responsible partly for her hip strain. Absolutely. She fell off a bike, for God's sakes, right? So, she's doing a lot of upper extremity sports as well. So, pickleball, tennis, you name it. So I absolutely think a loss of power, knowing what I know now, absolutely. Do you think that a poor performance, because I did check this on her, do you think that, her poor performance on a single leg squat, let's say she goes to 30 degrees of knee flexion, okay, she had an increased hip adduction angle. Do you think that's connected to her Jones fracture? I'm hoping you're all nodding and saying yes, right? And so once again, Allison Grimaldi, check out that masterclass on gluteal tendinopathy. It's absolutely related. The foot is, I saw someone yesterday who has, um, she had multiple ankle sprains, and she did a single leg squat. I thought she was gonna fall on the floor. The control was so poor. And on her other side, it was almost perfect. You see such a huge difference. Obviously, as clinicians, that's gonna raise our radar a bit. We would need to investigate that. And I would say no matter what she's coming in with, honestly, because that's going to transfer over to other tasks, right? So, I mentioned earlier that, you know, when we have declining estrogen, even if your patient is menstruating or if you are menstruating, your estrogen level will drop during your cycle, right? And so, what happens is that menopause and this loss of estrogen is really closely associated with the release. And these are for the science nerds out there. increased release of pro-inflammatory cytokines, hence that musculoskeletal syndrome, that increased pain, that chronic pain, and as we get older, interleukin 6 and tumor necrosis factor alpha. I'm not going to go into the biology of this, but just know that that does happen, right? These pro-inflammatory cytokines tend to they're higher when you have a loss of estrogen. And these chemicals, they can, generally increase fat mass, right? And compromise muscle function, causing sarcopenia, right? The loss of muscle strength and force as you get older. Um, you know, I'm not going to get into the whole hormone replacement stuff or issues, but I will mention a couple of studies because hormone replacement is not for everybody. There was a study done that showed that postmenopausal women taking hormone replacement therapy, probably estrogen or estrogen plus progesterone, are protected. Women who are on HRT are protected against the loss of power output. Think your jump height, medicine ball push, jumping power, increased speed, velocity, right? But not isometric strength. Okay. And these results are in agreement with other studies, concluding that hormone replacement therapy has a protective role in muscle power, but not necessarily strength, right? And so I think that for every study that you read that shows that HRT is beneficial, there's another one that shows it's not. And I think that it really depends on what you're trying to measure. I've done a lot of research on this and reading, and you could be measuring cross-sectional area. You could be of a muscle. You could be measuring, fat-free mass. You could be measuring vertical jump height, finger strength, grip strength, sit to stand, timed up and go. You name it, it depends on what you're measuring. It really does. I would just urge you to take that into account when you are reading the research. And I think that, the only thing that we can agree on is exercise, right? We all know exercise helps because, sarcopenia is inevitable. It's been shown, right? We all know that exercise helps, which is why my patient was, mountain biking, she was exercising like multiple times a week. Was she overtraining? Oh yeah, she was, right? She's a naturally lean person, but a lot of women tend to gain weight during menopause, and the first thing they turn to is cardio to get that weight down, right? And I think, and I will show you. I'll talk about a study in a second that I'm not sure that's the first thing you should be turning to be honest. I think guidelines that for optimal weight training in perimenopause and even postmenopausal women are still lacking. They really are. But once again, exercise is like the only thing that we can agree upon. I think the literature, it shows that or suggests in some studies I've read that resistance training using heavier weights and fewer reps is generally more effective at improving muscular power, which would make sense, right? Than lighter weights with higher repetitions. Intuitively, that all makes sense to us. So if we're trying to combat the loss of strength and power, then it makes sense to look at these recommendations more closely, right? My patient was doing a lot of working with the trainer, high reps, low weight, and so you think about as a physical therapist, why don't we know more now, right? Why don't you suggest to her or have a chat with the trainer and say, depending if it's safe, obviously, my patient, it was safe to do, higher weights, lower reps, you will get more bang for your buck. It'll be a more efficient session, to be quite honest. You want efficiency. And, there is also growing consensus. I'm going to cite a study in a second that both high intensity high intensity interval training and overall strength training really can reduce the accumulation of visceral fat that we see and we commonly see during menopause, right? And helps mitigate the loss of muscle mass, right? So there is a study that I will tell you is fascinating. It's done recently, actually in 2025, by Yaris, Yaris et al. And I'll give you the title in case you want to look it up. Impact of high intensity interval training on bone metabolism and the metabolic and hormonal profiles of postmenopausal women. That is an earful. I can link to it at some point if you guys want it, but impact of high intensity interval training on bone metabolism and the metabolic and hormonal profiles of postmenopausal women. So I'll be very brief. They had a total of 32 postmenopausal women. Exercise group was 15. The control group was 17 participants. Okay. Uh, I'm just going to briefly talk about what they did. Okay. They had an exercise group. They put them on 6 weeks on a stationary bike. HIIT training tends to, people either run or they do that on the bike. The bike seems to be the better way to do that, but you certainly can do it with running, right? They put them on a stationary bike 3 days a week. We're talking 3 days. Okay. With 30 seconds on, high intensity, 90 seconds off, lower intensity. So 1 to 3. Okay, 3 days a week, 30 seconds on, 90 seconds off, with 90 to 95% of the heart rate reserve at that high intensity. 12 to 16 minutes a day for 3 days. Okay, so 3 days a week on a bike for 6 weeks. 30 seconds on, 90 seconds off, 90 to 95% of heart rate reserve, 12 to 16 minutes a day. They titrated that up to, I think, 19 minutes at one point. In the exercise group, significant reductions were noted in waist and hip circumference and other measures of the metabolism. I'm not going to go into LDL, cholesterol, triglycerides, all dropped. Okay. They also looked at they had lower cortisol, big thing. Look, cortisol levels were dropped, right? So 3 days a week for, let's say, at most 19 minutes, doing HIIT training 1 to 3, and this is what you get. I think this is significant. You don't need to do much, but you need to do something, right? So I think about with your patients, at the very least, educate them as to some of this research and educate them on to the importance of using weights, obviously. It's real important as these women get older. And I've seen it. I took a class from for my doctorates probably a couple of years ago. And I saw an x-ray of a woman who had a hip replacement because she felt she had osteoporosis. She developed avascular necrosis. Okay, yeah, post-op hip replacement. When I tell you, looking at that x-ray with the avascular necrosis and the hardware, like like you want to literally be doing everything you possibly can to avoid that. I mean, no surgeon would touch her. I mean, they basically did a revision, but she was non-ambulatory and wheelchair bound for most of her life after that. And so the mortality rate is huge. So really think about, at least educating your patients on this. I know we all do, but it's just a gentle reminder. And so my patients, I'm going to be very brief because I promised I would be short. Her drivers for all of that left-sided neck pain, left-sided shoulder pain, back pain, hip pain, foot pain. Her drivers were her thorax. No surprise there for those of you who have listened to our podcast for a long time. And her foot. And so with all that about what I've just talked about and for those of you who have been listening to the podcast for a long time, I want you to think about, pick 3 starting exercises you would give her. I will tell you what I did. 3 exercises, knowing that her foot is a strong driver as well as her thorax. Okay. She's fallen multiple times off a bike, right? She tore her hamstring. It's trauma, right? Whenever we have an injury, just another clinical pearl. If someone has, let's say, ACL, you have somebody who's post-op ACL, post-op hip, post-op foot, how are they going to offload their weight? They're going to do it through their thorax. It is easy to do. And I'm putting easy in quotes. But we never train them to get back on. We never train them to center themselves. But the therapists that are doing that, that's amazing. You need to get your patient back to loading more of that side in all tasks. So someone has a left knee injury in their history. Doesn't even matter if you're treating that injury right now. You need to take a look at the thorax, okay? If you have an ACL, as I said, ACL, hip, foot, look at how they're transferring weight eventually when you get to that phase of rehab, okay? So how can we be more effective for this particular patient? What's her underlying tissue impairment? Once again, is it overactive? Is it underactive? I mean, I highly doubt it was underactive in her case. It's very rare that you see that. It's usually an overactive system or a neuromuscular imbalance, which I don't think would be news to anybody who listens to this podcast, right? You're not going to start her in standing. I would not because of her right foot. Okay. You know, from our episodes that we talk about normal stance, space of support, wide and narrow. Okay. If you have somebody in standing and they're in a normal base versus wide or narrow, if they're worse looking versus looking wide and looking, and I'm putting in quotes, right? Then there has to be something in that lower extremity, right? So this person, if she stood for a living, which she doesn't, I would caution her to stand with to maybe go with a little bit more wider base of support when she's standing. Because when she stood narrow, her squat was so far off. She almost fell over. So I would, when anybody who has that issue, I would certainly say if you're standing, you're doing a lot of standing. If it bothers you at a cocktail party, I have a couple of patients who are like, when I'm at a cocktail party, everything bothers me. I'm like, stand with a wider base because I know the foot is in there, is part of their issue. So let's say she told me she had 5 minutes for exercise. I'm like, you do, you're running and you're seeing a trainer. Yeah, how come you only have 5 minutes for exercise? So, but she wanted just to devote that. And so it is what it is. You have to work with what you're given, right? So if she can't lie supine, I'm sorry, if she can lie supine, what I did start her off with, and I think those of you who listen to the podcast will know, wrap a yellow TheraBand just above their wrists and have her, do a three-way TheraBand. So you push out against the yellow TheraBand about 5%. You do a chest press, you do an overhead shoulder flexion, and then you can do skull crushers, right? Triceps. So, but that gives her control of her thorax, which is one of her drivers. If she cannot lie supine because of bracing, it is extremely common in these patients to have very taut hypertonic erectors. I had a patient who was an equestrian and she had significant bracing throughout her thorax and her lumbar spine. I put her in supine, she was a mess. And so a lot of people are like that. Just so you know, how are you going to start her then? You're not going to have her go on her back and do the yellow TheraBand, right? I put her on her hands and knees. It's a great way to start. Get them loading through their arms just to start. This is the start of the program. This is not like down the road, right? You can wrap a TheraBand around their hands if you want to give some input, but get on her hands and knees, right? I didn't want to do it in start her in standing because of her foot issue. Clearly, her foot needs to get treated, right? So if you progress through that and they can lie on their back, think about this: have them go into a bridge and have them do the same yellow TheraBand arms I just talked about, but in a bridge position. You are sort of working with her foot, right? A little bit. She is loading, but she's doing a lot of great movement patterning for her thorax. Or if you want to do closed chain, you can have her just do a wall land where she just literally winds her arms up out to the side and lands on the wall. Anybody needs a visual on that, let me know. And so clearly her foot needs to get released and trained because she won't get back to where she needs to be without you treating that. And so you need to get her upright at some point to do her exercises and progress. You need to clear her foot out. I'm not going to go into how we treat the foot, or everybody treats it differently, but know that it needs to get treated sooner rather than later, or you will be stymied. Honestly, you will be stymied in your exercise progression. So I think that's it for me. And once again, this is supposed to be a shorty. For those of you who have any questions on either my dissertation research or any of my case study, I did a very brief case study, but with her in the end, I just wanted to discuss the fact that she was in menopause, and she had a lot of symptoms that were very much related to her menopause, but she was active, very active. And if you have patients that are active, and who are on hormones, for example, as she was, they tend to do better than women who are not physically active, right? So, which makes sense. In a couple of studies I did read, I'm going to be measuring physical activity, probably with a short form questionnaire. But there are a lot of women out there there's one study I read, this was a while ago. I have to pull it up. I feel like I've been at this forever. Where they had a group of women who were very high physical activity and on HRT. They literally performed almost equal to their premenopausal peers. So physical activity is really the name of the game here, but we need to titrate that with patients, and we need to talk to them about, the high intensity interval. We need to talk about, the power. A lot of you're seeing a lot of recommendations out now for this HIIT and the power work, right? But I said to myself, but no one has measured power in women. Very few people have, in pre and postmenopausal women, which is one of the reasons why, which is the reason why I wanted to do this study. So anyway, hope that is it. Anybody has any questions, you know where to reach me. Mine am Erica at ericamello.com. And we will see you guys soon. Bye.